Welcome back to this week's episode of the Caregivers podcast. I'm your host, Dr. Mark Ropolewski, and you can call me Dr. Mark. Many families are afraid of long-term care before they even walk through the doors. They've heard the stories, they've seen the warnings, and then one day, someone they love is there. You press the call bell, you wait. You watch someone you love need help, and part of you starts to wonder, why isn't anyone coming? Today we're asking what is happening on the other side of that moment. Where is the nurse? Who else needs them at the same time? What are they being forced to choose between? And when care feels rushed, delayed, or inconsistent, how much of that is the nurse in front of you, and how much is being shaped by staffing levels, budgets, and management decisions inside the facility? This conversation is about the space between families and nurses, the fears families bring, the anger that can land on the nurse on duty, the impossible choices nurses are forced to make, and what happens when good people are asked to provide care in conditions that often make good care difficult to deliver. Our guest today is Nurse Chrystal Moran. Chrystal is a long-term care nurse, a mother, a patient herself, and one of the most outspoken public voices describing what nurses are actually living inside. Chrystal, welcome to the Caregivers podcast. Before we begin today, please take a moment and subscribe or follow the Caregivers podcast wherever you're listening or watching. It's free, and it helps support the show. And it helps these conversations reach more caregivers and families who are trying to protect someone they love. Chrystal Moran, welcome to the Caregivers podcast. We're so happy you're here with us today.
Thank you so much. I'm glad to be here.
So in the tradition of this podcast, we like to jump in from the start. So tell us, Chrystal, when a family is in a long-term care facility watching someone they love wait for help, what are they usually not seeing about where the nurse actually is, who else needs them, and what choice the nurses need to make before being forced to make in that moment?
Well, I think that obviously there are seen and unseen sides of any situation. In the nursing home specifically, what families don't usually see, sorry, my cat is creeping in. What families don't usually see is the schedule. The other human beings who have similar problems, maybe more extensive problems, maybe something trivial. I might spend an extra 10 minutes in the room with someone and it sounds like trivial conversation, but it's really just to make them feel more comfortable or more at ease. They're having a lot of anxiety. There are different, tasks that we are charged with, but ultimately the schedule is just so full. Everything nowadays is budget-centered care, and I don't mean that across the board. There are still a few rare facilities where this doesn't happen, but by and large, we are overworked, we are understaffed, and everything needs to be done right now. So how do you prioritize, human beings and human needs, basically, is what happens. So the family member doesn't see that the reason the nurse sounds like she's kind of shooting the bull with Mr. So-and-so next door is really that she's trying to make him feel more comfortable. He had a rough night. Maybe he's going through something in his personal life with a family member or something like that. And then on the other side of that, the nurses are trying desperately to manage their time. The CNAs are swamped. There is absolutely no way to get all the work done. So you're basically just trying to get through a round, basically, is the entire shift. And so I feel like we do our best to prioritize, but ultimately it's a broken system and we're doing our best with what we have.
And those 10-minute conversations are so important for building patient and I think family-centered connection as a professional caregiver, right?
You're absolutely right. I think that for you to trust me with your life or with your mother's life, you need to know basically how I'm going to respond to her needs, whether they be a critical, moment of care where we've got to respond kind of quickly and know what's going on, or whether you're more concerned with the day-to-day. How are you going to be with her on each interaction? How does she respond to you? That kind of thing. So, and if it were you yourself, you would want to find some kind of a connection like, okay, she's a good one. She remembers what I said yesterday, or she knows that this is my preference about such and such. She communicates with the other staff things that I've said I want or I need, things like that. I think that's very, very important whenever you're trying to care for human beings. It's not, you didn't pull your vehicle in here for something as impersonal as maybe a tire change. You're living here. This is your home. So it's very important that you know who is coming in your door, who is taking care of you, who is going to care for your loved one. Absolutely.
Certainly, in the setting of longitudinal care, such an important additional step, but definitely one which can make one person in need have to wait a little bit longer for the person to finish with someone else. When families are scared and angry in that moment, Crystal, are they wrong to feel that way, or are they just kind of missing the larger, bigger picture?
Well, I think that communication ultimately will decide which side of that we kind of fall on. If the family member has been given or the resident has been given zero information, they are only right to assume whatever it is that they see. So if they experience no communication and the nurse just evaporated into thin air, they're not wrong to assume she got lost or she prioritized somebody else, or for whatever reason she's not in front of you. He or she is not in front of you. And I don't think that they're wrong to feel that way, but I think that we can do a better job as healthcare professionals of saying, hey, I hate to tell a staff member, excuse me, I hate to tell a resident that we are short staffed, but I like to communicate with them realistic time goals. If you're looking for your noon medication, for example, I try to be as routine as possible, but sometimes deviations happen, real life occurs. And as long as I communicate that with you, your expectations can match what I'm realistically going to provide. So I think as care providers, we have to be realistic and communicate. Use your words. You know that you're swamped today, so don't promise Mr. Smith that you're going to be back in 5 minutes or that you're going to have his noon medication promptly at 12 o'clock. I think that we have to kind of bridge that gap with communication.
Is all communication safe, or is it sometimes unsafe for the professional caregiver to say we're short staffed?
I wouldn't necessarily say that we're short staffed, but if someone draws that conclusion accurately from the things that I have said, then, they're not wrong to feel that way. It's an accurate depiction of what's going on. I think that the responsibility is on these facilities to do a better job of staffing and managing expectations. They sell them the world on admission. I feel like they, promise them quick response times and, all these different preferences just to get them in the building. And again, this is not all facilities, but so many times I've seen this, they will oversell. And then we, as care providers, are under delivering based on those promises. And I think that the facilities can do a better job to make that happen. But no, I traditionally try not to tell someone just blatantly we are short staffed. They would be able to read context clues like the look on my face and the sweat on my brow and my scarcity, the fact that I'm all over the place. If they draw that conclusion, they're not wrong.
A lot of families are already afraid of long term care even before they walk through the front doors, and they've heard the horror stories, and I'm sure some of those fears are not irrational. What are they right to be worried about today?
Today, I would be concerned with a lack of supervision. So, if you are putting a loved one in a facility where you will not be able to visit routinely or you don't have family close by in the area, you need to get a friend, an advocate involved, someone that can lay eyes on your loved one and listen to them if they're able to verbalize, kind of their experiences and things like that. Believe them, obviously, if they tell you that something is wrong. But I think that ultimately, you're right to be afraid of a situation that you have zero control over. You can use your voice as much as the next person, but ultimately, the care is going to be provided by someone other than yourself. And you have to believe that the facility is going to do that for you. I have seen, again, multiple times where it's just not the case. And you advocate as care providers, we advocate on our side for the things that we see that we feel like are deficient or that we don't feel like are, justified to these residents. And obviously, we're mandated reporters of things that fall well below the standard. But I think that, to be afraid to put your resident in long term care, I wouldn't say that so much as because there are so many of us that do care and that do show up to work and do our absolute best to make those people feel welcome and comfortable and, and top tier care. I think that there are a lot of clinicians out here doing that. But I also think that your fears are valid. You're out of control. You can't be everywhere all the time. And then whenever things happen, you kind of question, well, what was the root cause of this? If something is not sitting right with you, though, I would say question it. Absolutely. If something just does not seem right, completely full force, yes, please question it.
So, looking from 35,000 feet, where do you see the biggest disconnect between, let's say, what families expect and what most facilities can actually deliver?
I feel like the expectations that are set forth, like I said, in the admissions process, I feel like that's probably the biggest disconnect because they need the census, they need the head in the bed, they need the body. Uh, they need these people to be admitted so that they can continue to provide care. But I think that the largest disconnect for me is in admissions. As a facility, we will tell them whatever it is that they want to hear to get that process done because it's so salesy. It's like buying a vehicle, except this is where you're going to live. So I strongly encourage to conquer that. I strongly encourage families to show up at odd times, to show up unannounced, just to get a full picture of kind of how things go. Show up at a mealtime, see how chaotic that is. Or if it's a rare building, it's not chaotic, but that's going to be the smaller portion. Most of these facilities are owned by large corporations, and budget is the key component in how we can care for these patients. I would love to say that it's all patient-centered care per CMS guidelines, but it's just not the case. It's more budget-centered in these facilities today.
It reminds me of a conversation we had a while back with Janice Martin, who equally said, when you're touring, don't underrepresent the needs of your loved one, and only to see them mount afterwards, because there may be a disconnect between what is offered or what can be provided as opposed to what's truly needed. Do you see that happening often where, the report you get on the individual coming in is so and so, and then when you realize what the care needs are at the bedside, there's a complete disconnect?
Oh, absolutely. That's a great point. A lot of what comes to mind most often is psychiatric needs. So for our residents who come in who are on maybe some mental health medications, who have had some behaviors in the past, maybe maybe this is a new norm for them. Maybe they went through an event like a stroke or some kind of hospital stay, and this is the new person. Either those behaviors were not witnessed prior to, or those behaviors had to be buried to get that person approved for a stay in a facility full of defenseless people. So sometimes we have residents who come in who have no psych history. Maybe they were unhoused, experiencing homelessness, and they have no real history. And then suddenly they come in, and we are finding out that they do have physical, behaviors. They have some mental needs that we were ill-equipped to deal with until we experience those firsthand. And sometimes that takes a little while to kind of unravel, whether it's because there was a change in medications whenever they admitted to the facility, or whether that drug was not quite in therapeutic range. Maybe they started a new med in the hospital and just hadn't quite hit yet. And also a change in your environment, if you're experiencing mental health difficulties, can be very triggering. I think that moving from place to place and it's still not home is very triggering. So definitely psychiatric cases definitely come to mind there, where we have no idea, really, either like I said, they weren't witnessed to do these things at the hospital or have these needs at the hospital, and then traditionally they'll come into the facility and we have to really work through those things. And long-term care, as much as the reputation in the 80s would be, that we would chemically restrain people if you were acting out and things like that. We gave a lot of sedatives. We used restraints. We don't use those things anymore. And the laws have now changed with psychiatric medications. So we're doing our best to let people just be who they are without medications. And then, you have to show that you've been through all the interventions, that you've done everything you can before you get to that point. So sometimes it's just a mixed bag. You have no idea who that person is until they show you who they are.
Boy, when you're stretched thin, if you think about the amount of time it takes just to build trust with those individual patients as a nurse and an allied health team, I'm not sure if that extra time to build trust in the therapeutics and the plan are really factored into assignments and shift detail and ratios.
No, I don't think they are. I think that ultimately it just boils down to how many people can we take, and the schedule up is divided by number. not by need or acuity, which is something that I have harped on for years. I think that there being no federal guidelines based on acuity, that's a huge problem for me because I might have 10 total care people and have the other side of the building and you have people who are able to walk independently or who need your care less. And so, yeah, I absolutely wish that it had been mandated. If these facilities are not required to do it, that will never happen.
So, Crystal, what does it do to a long term care nurse to walk into a shift knowing they may have to delay tending to someone or worry a family or leave a need unmet, even if they work as hard as they possibly can?
Let me tell you, that is a mental marathon. And I don't think enough is said about the fight or flight response in your body. When I'm still a human being, I'm going to clock out at some point and go home to my family and live a life. But I am constantly in fight or flight because of the nature of long term care. You feel guilty. You ride this roller coaster of emotions, guilt, inadequacy. You feel like coulda, woulda, shoulda. Maybe if I had done this differently, and you're constantly like reevaluating your shift. And God forbid you should have something going on in your personal life. Like you've got a concern or something that's kind of eating away at you. You better leave all of that behind because this job will eat you alive. And it did that to me. And now I work on, the other side of that in the courtroom and I advocate for patients that way. And that has really helped my mental health because like I said, the constant battle of can you get everything done? I am extremely neurotic because of my work in nursing. I know that sounds crazy, but you become
No.
OCD, you become COVID definitely enhanced my OCD, cleanliness and infection control procedures and trying desperately to keep these people from getting in contact with these microorganisms and things like that. I feel like not enough is said about the person that you become, the traits that you have to acquire for your survival in long-term care. You have to be able to turn it off at the end of the day. There's no way to meet every need. I've had nightmares about forgetting to do XYZ. It might be anything from bring a glass of water to putting a call light back in reach, thinking, well, how long was it before so and so got their call light back? Or, did I put that call light back? Just different things. It will eat you alive, honestly. It is brutal.
As a long-term care nurse, when you walk out at the end of a shift, do you remember the people you were able to help? Or is it a rumination and perseveration about the people you just couldn't get to fast enough?
I think the empath in me is more concerned with the unmet need than reveling in the accomplishment of completing these things. Yes, it does feel good whenever someone pats you on the back and says thank you or job well done, or whenever you're able to, solve a problem, work with a provider that you've never worked with before. They're little successes, but they are heavily outweighed, in my mind at least, by the things that I was unable to do or the things that I felt were unfair that happened in the shift, to another resident or another employee, things like that.
And you're not often the determinant of the fairness, right? You're just sort of the mediator of the process.
Right. I
In
mean,
long
you're
term,
you're the face of a broken system at this point. We're the spokes in the wheel, So
so in long term care, then, when more than one resident needs you at the same time, how do you make the decision no family wants to imagine? Who gets care first and who has to wait?
I think resourcefulness is a big thing. So if for some reason, depending on what it is, depending on why these two individuals need a nurse at one time, you just have to prioritize like what is the most critical. If I don't see this person in the next 5 minutes, are they going to die? I would then be resourceful enough to get a colleague, someone to, hey, sit with this person or do this, delegate, uh, as best you can. Sometimes there's no one available, and you really do just have to make someone wait. I've gone back and forth multiple times with two patients that were not doing well at the same time. That unfortunately that happens a lot on night shift whenever we
Hmm.
are at the lowest staffing levels for the day. But yeah, just delegating and being as resourceful as possible. Get someone, on a breathing treatment while you run over here and help this person to the restroom or what have you. So certainly it's doing the best with what you have, but it's an imperfect system, and it ultimately the care provider is the person who really just feels distraught. It's like, well, how do you decide? But I
Hmm.
try to treat everyone as if they were my family, probably better than I would treat my family because I'm probably not as harsh about bad decisions and things like that, not as critical as I would be if it were my own family. But certainly try to treat everyone with the respect that they truly deserve.
Can you share with us, Chrystal, what's the highest patient to nurse ratio you've ever experienced on a night shift?
54 to 1, 54 patients to one nurse.
How do you rationalize that in 2026?
I can't. It is becoming with the community that I have on social media, they tell me things, and some things I'm allowed to talk about, and some things are just letting them vent privately. But I have heard 60 to 1. I have heard just over 60 to one patient, and that is criminal. You are setting me up as there's no way to succeed like that. One person gets sick and another person has a fall. What do you do? There's absolutely no way to manage all of that. And then to add to that, we rush people through orientation. Traditionally, these facilities will rush you through an orientation if you get one. They just assume that long-term care, and it's 926-page manual because you graduated with a nursing degree, and then or a CNA certification, and then you get to night shift, and all of these things are going. It's it's the most damned system. Like there's no winning. And I scream at the top of my lungs, Mark, because I know I can see the train that we're on. So many providers know exactly how this is going to go, and we accept it because we know that to stop the system the way that it is, we have to stop. And we know that that would cause harm to people. We know that, needs would go unmet. And, if every nurse everywhere decided, hey, we've all had enough of this, it would destroy the system that is barely functioning. So we take barely functioning and just keep going. And ultimately, I think it's going to take a complete shutdown of long-term care the way it currently exists. I just don't think that it's one of those things you can just see. You just know.
So, how are new nurses then taught to deal with multiple competing interests? Is there a mentorship
They are not.
agreement?
They are not. And they are taking their own license into their hands whenever they take these assignments. Whenever you take these keys, whenever you take that report, you are quite literally in a balancing act now with your career because it takes one allegation. It could be a false allegation. It takes one accident. You get an immediate jeopardy. They are questioning every single thing that you did. They are, witness statements for every single thing that went on that shift. And then if you are found to have, been in deficient practice, that's your license. These new nurses, I was working in a facility in Indiana that would hire in, they would hire in RNs because of the 24-hour rule, and these RNs were fresh graduates. And it's not that they didn't know anything. They knew how to do nursing things. They were not, however, familiar with long-term care.
What's the
There is
24-hour
so
rule?
much.
Sorry.
I'm sorry.
With the 24-hour rule, can you just explain that?
So, the Office of Long-Term Care, Centers for Medicare Services, CMS, mandated, and that has since been repealed, but they mandated that we had to have 24-hour RN coverage, and that would help. I believe it would help with a certain level of reimbursement if you could say, government, Medicare, we
Mm.
have 24 hours of RN coverage, not just LPNs. They've since pulled that back to where it's no longer required. But at that time, they were hiring in people with that certification, the RN level licensure so that they could meet that rule. Those people were not equipped. A lot of those people were brought straight from nursing school. And that has its own advantages. You can teach someone everything that you need them to know versus having to unlearn acute care or something like that. But ultimately, you need time to be able to understand how long-term care works. There are so many nuances to long-term care, and it's a complete shift from everything you learned in the med surge floors, the OB work, all the different clinicals that you do, the rotations that you do in nursing school. Those do not prepare you for long-term care whatsoever. So I think that it's terrifying. It's terrifying that your mother is with someone who knows very little about what's going on, is also very spread thin, and then to the people that, find themselves in these situations, they are unaware of how much responsibility they are taking on whenever they do this. It's unlike any other animal, really.
So when a family's angry because someone they love has been left waiting, has had a basic need go unmet, or sat with an unanswered call bell, the nurse on duty often becomes the person held responsible. But how can families actually tell whether the problem is the nurse standing in front of them or the staffing levels, the budgets, and the management decisions at that long-term care facility? I mean, families and nurses should be on the same side, right?
Absolutely. And we both are working hard to, provide the care that patient needs, that resident needs. The problem is, like I said before, I can't really say, "Hey, Mark, I would love to be there, but we're short staffed and I've got to go give 3 showers." I can't really say that without violating probably some kind of policy. And then ultimately, if people hear short staff, they attribute everything to short staffing, and then the building gets, the administrative staff gets upset. Why would you tell them that? Don't tell them that. Then they, are looking for a problem, and I understand why they do it, and I try my best to avoid that conversation. However, I think that when a family has a problem, number one, approach with dignity, because you have no idea if the person that you're speaking to is the person that is responsible for whatever it is that feel like failed, the system that failed, or the policy that was broken, what have you. Sometimes it's not that person's fault, and they have absolute, they just picked up a shift because someone needed to take over. But I would also say to the staff, communicate like, "Hey, I'm doing my best, and she said that she had to use the bathroom first. Why is she late for this appointment? Well, we had to leave to go back to the bathroom before we could take her," or whatever the case is. Communication is key. And people get so buried in their work that they forget, just talk, just explain like you would to anybody else what's going on. And that goes a long way. And ultimately, if we get to talking, you're going to also tell me some other things that maybe make you uncomfortable. And maybe I can head off some things. Maybe we can make a better plan so that we don't get to this particular moment every time, the call button is pushed, or every time you come in for a visit, you're handling things that you don't think were handled appropriately, or what have you. You're trying to put out fires all the time, and it's a very reactive approach when sometimes we can just talk and make a plan. The problem there for the family is going to be consistency in caregivers. You may see my face once every 2 weeks.
Yep.
I may be on this assignment once every couple of weeks. I may not have your resident that day. So it's very important, again, that we communicate shift to shift and that we update care plans, because I really do look at care plans. I want to know why this lady cries if the window, shade is up. I want to know why this person, you know what I'm saying? Like, it explains a lot about how these people are. So providing the continuity of care starts with updating that care plan. Let's keep those as up to date as possible so that we understand exactly how best to care for these people.
Well, you answered my follow-up question to the T, is that, so much of the connection that's required for optimal patient care at the bedside and long-term care does depend on that extra level of communication between
Mhm.
provider and family, and it translates into basic tenets like trust and others. But if you don't have, consistency in the duty assignment, I can't imagine how the efforts actually pay off longitudinally, as opposed to just sort of being in the moment, but then they're not really banked in any way in terms of continuity, but hopefully those care plans capture it. Is there enough time at the end of the day to make sure the care plan's up to date?
Probably not for the nurse who's working that assignment. There is so much charting and there are so many, assessments that have to be done to be able to bill for Medicare, Medicaid, what have you. But I think that if I were in a position that I was unable to complete an update on a care plan, and a lot of nurses are just not familiar with how to do that based on, the fact that someone else usually manages the care plan, if it's social services, if it's, the DON, whoever it is in your building, I think that a quick email, a quick phone call to that person. Hey, this person really doesn't like this. Can we update the care plan? A lot of times it's dietary, a lot of
Mm-hmm.
times mealtime, it's kind of chaotic. I may not have time at mealtime to update that care plan, but if I call the person who usually manages those things, usually you can get those things added. I think it's just being consistent and writing it down if you can't do it right now, so that you don't forget. But that way the family doesn't have to repeat themselves and grow more and more frustrated with every time that this happens because they've tried to explain it to you and then you disappeared for 2 weeks, So I claw at any opportunity to finish something so that it doesn't just continue on.
You talk very openly about staffing and budgets and ownership and money in long-term care, but when families are trying to understand why care feels rushed, why it's delayed or, inconsistent, what do you want them to know about the business decisions between and behind bedside care?
Remember that just like we are trying to hustle through care, you may see us feel a bit rushed. Remember that there are X number of people, 2 or 3 other people behind you that are waiting for us. And so we're not skipping care, we're trying to provide the best possible care we can in a circular formation. So we just start around and then just keep going until everybody is seen. And we only have so many hours of the day to do that. It is absolutely impossible. And do I wish that there was more time? Absolutely. Do I wish that we had more time per person to be able to truly learn their preferences and take care of them? Absolutely. But I want families to know that if we're rushing, it's because we're trying to get to the other people. There's always somebody that needs something. And so if it feels rushed, it is not because we don't care about your person, quite the opposite. It's because we care about everyone so much that we are trying to manage an impossible assignment. I mean, truly, on my best day in the nursing home, I still had probably double what I should have to be able to adequately care for these people.
So, where and how then do families actually feel those financial decisions and management decisions at the bedside?
I I feel like quick response is delayed quite often. You may press the call button, and if I'm walking right by, I'll pop my head in and see what's going on. But sometimes you wait for 20 or 30 minutes for a need, and sometimes if you're not able to get out of the bed and come to the nurse's station to ask about whatever it is, you're at a disadvantage. I think that families being able to advocate is their given right, and I encourage families to use like resident council meetings and grievance forums to air out their concerns so that it's documented. But I also want you to understand that we're not rushing because we don't care. Quite the opposite. So, I mean, I would say to answer your question, more than likely you're going to feel like we're rushed or that it took us a long time to get to you. And sometimes, if you're waiting to go to the bathroom, for example, you know how that ends up. Um, it's really just, it's so broken. It's the hill that I'm going to die on. It is my legacy to raise hell until somebody hears us, until somebody says, you know what? They've got a point. Like that, this can't continue. And eventually, my dad will get old enough to need care, and my kids will put me in a facility, and all that. What will healthcare be like? And I don't just mean long term care, but in general, what will healthcare be then? If it's profits over patients now, imagine. You know.
Well, families may see a nurse who seems tired, rushed, or emotionally guarded. And I mean, in those instances, is burnout even the right word for nurses who still care deeply but are working in conditions where they can't provide the care they truly believe people deserve? Or is it moral injury?
I think there's a difference. I think occasionally you get to a point where you are exhausted. You experience what I would call compassion fatigue.
Hmm.
And so it's hard for me to care about the level of ice in your cup over the fact that, someone who was burned out ripped the sleeves off of this lady the other day and degloved her entire arm. Yes, that really happened. Um, it's hard for me to care as much about the level of ice in your cup as I care about someone who was abused or neglected in some way. Those things, I think, in the grand scheme of things, I experience compassion fatigue with the little things versus which, everybody's entitled to their little preferences and little quirks, and I have my own. But I think that ultimately the distinction between burnout and compassion fatigue are, and I would say compassion fatigue, moral injury, is aggravation. Whenever you are so aggravated that you have to do your job, you are aggravated at the staffing, when you just feel like your entire personality could be captured by saying the word aggravated, that's when you need to step away. And that's when there's a shift and you are more prone to make mistakes. You're more prone to be verbally abusive. You're more prone to, um,
Be cynical.
absolutely. I mean, jaded, it's a hard job. And I think recognizing when you're at your personal limitations, just because I've been doing this for 16 years doesn't mean that you're not going to be burned out in 6 months. That doesn't mean that I've done it consistently for 16 years or whatever the case is. And so I think that the fact that it's driven by the staff member to just to know whenever, to self-reflect and know like, hey, I'm reaching that point, but I also have to earn an income. Like, how do I just say, you know what, job, I can't do you for, like, I don't know, 6 weeks. I have a girlfriend who recently, she and I have worked together for over a decade. Like, we've known each other for a really long time. She's been a nurse for 30 something years. And she was recently in long term care and she had to step away. She took family medical leave and she stepped away because her mental health was just toast. And I think that if she had not stayed, she would have fallen into that bucket of burnout. She just couldn't take it anymore. And I think aggravation was probably her top trait. Like, she was already irritated before she walked in the building. And I obviously we all have those shifts, we all have those days, but whenever you feel like that's not a fleeting thing, it's time to step away. And families will notice, residents will notice, people will take notice whenever your demeanor is not compassionate.
There's that transition from aggravation, which I think everyone in healthcare has felt at times. But once the situation or the decisions you need to make start conflicting with your own deep moral values as a provider, as a care provider, that's where moral injury rests. Have you ever
Yeah.
felt morally injured yourself?
Not necessarily. I do I do my best to separate how I feel about a certain situation versus how a resident feels. Yes, I try to put myself in their shoes to some extent, but I do my best to try to just separate from that. And so I have experienced what I would call burnout several times, and I do see moral injury. I see that. I think it's more discussed now than it traditionally would
Hmm.
have been years ago. Thankfully, social media has really helped that, where people are able to kind of express where they are and how they got there. But I would say uh, I've not experienced that necessarily in those words. I would say that I've reached the burnout point several times, and for those reasons, I'm not practicing as a nurse right now. I just just need some time. And I've gone to different specialties and done different things, but geriatrics is the love of my life. So actually yesterday, um, true story, I went to the store and just bought a whole bunch of stuff and just showed up for the staff. Like, I just dropped it off. I didn't put a note on it to say my name. I didn't say anything about social media. Like, I genuinely just wanted them to know that, like, someone sees you, knows what you're doing, and part of the gift that I left was things that were things that would help do your job, or things that would make your job easier, things like that. So, I think that not enough people, I won't say that. I think that showing our support and solidifying as a group is the only way that we can change this about long-term care.
You've stood in the face of burnout on several occasions. You just told me. Is the hardest part really the workload itself, or is it knowing that the conditions inside the facilities are just keeping you from being the kind of nurse you came there to be?
I think the most frustrating part for me is feeling like these people just deserve better, you know? I feel at the end of the day when you clock out, you're like, "Well, are they gonna be cared for? What's the assignment going to look like tonight? How long is that person going to scream? Are they going to close the fire doors so that they don't have to listen to that person scream? You worry constantly because it's like an extension of your family in some way, like for at least 8 or 12 hours or whatever, you're treating these people like family. And so you worry about all the things that are going on when you're not there. I was a nurse manager for a building, and I showed up at like 1:30 in the morning just to do a round and see what was going on, because I had a sneaking suspicion that, that things were not well in the middle of the night. I was hearing tales of people, sleeping in their vehicle and not showing up, and, I was coming in the morning and things just didn't seem to be done, and the assignments at that time were reasonable, for, 2026 long-term care. And I just did that out of caution that, if I'm not here and I hear things, then I should probably check. And those types of it was a snowstorm whenever I did it, the last time, and you're quite literally risking your own life to go out and check because you feel like these people deserve better. It's so frustrating that you have to go to these lengths to make sure that these people are cared for. Not everyone views long-term care the same way. I would say there are some generational differences, amongst the staff that you see in these facilities, and maybe in the workplace in general, in this country. Maybe generational gaps, all operate a little bit differently, or experience things in different ways. But yeah, it's terribly frustrating for me that I have to leave and I have no idea what's going to happen. I've had more than one crash out on the internet about things that I found because it just pissed me off. How do you work in a profession that requires you to care for human beings, to value human life? I don't know. I think several things can be true at the same time, and for me, the burnout came from constantly worrying about what was happening when I wasn't there. So,
It's guided by that type of empathy and commitment. It's pretty hard to leave work at work and come home
mhm.
to your family, isn't it?
Absolutely. There's always something to keep your mind occupied at work even when you're not there, you know? So,
Families often judge care by what they see, and that's best shown by whether someone came quickly, whether medication arrived on time, or whether a need was met. But what parts of nursing and long-term care are families really not seeing at all?
that's a really good question. Obviously, the families don't see the worry that we have outside of those walls. They don't know that we go home and think about. I know, nurses that are praying for their residents and the things that those families might be going through. Um, I would say more often than not, they don't see the empathy that we have, that we truly do suffer along with them. We truly do worry about, probably as much or more so because we're kind of on the inside. We know the things to worry about, more so than the family member. I don't think that families would believe it if we explained exactly how much of our time, our thoughts are consumed by what's going on at work with that resident.
That's an important message to spread for sure. If someone followed you on an ordinary shift, what do you think would surprise them most about how little of the task they were waiting for is just a fraction of what nursing entails?
Trying to think of a good example for that. Let's say mealtime. I mean, things are so highly regulated that when we follow all of the steps to complete a task, we have spent exceptionally more time preparing for, explaining, then carrying out whatever it was, the orders, the doctor's orders, or whatever the thing was, and then the cleanup or whatever we do to close that down, whatever we do to end that task. It sometimes is a lot. I'm trying to, besides meal times, I don't know. I guess it's just so highly regulated because if you're doing something in the nursing home, there is 100% a rule or 50 about it. It could be anything from, I go in to refill your ice water. Okay. I have to knock on your door. I have to announce my name. I have to request permission to come into your room. I have to wash my hands. I have to, remove the cup and bring in a new one with a fresh date and a time and I say all that just to say there's so many rules to what we're doing that it's not ever just, oh, let me run in and go do this, or it's not supposed to be. I mean, there's rules about that kind of stuff. You have to explain what you're doing. You have to sorry, I'm turning my fan on. You have to explain what you're doing. You have to ask for permission to do it. You have to make sure that the person is comfortable. You have to assess. You have to um, follow up and whatever the outcome was of the situation, you have to document everything. There's just a lot that goes on from A to C. It's unseen, but there's a lot that goes on.
You could see how not being aware of those details and that process that's involved in so many of the steps that are involved in delivering care, that it could lead to tension and
Mhm.
impatience even. I mean, in long-term care, families are there to, when they can be, to try and protect and advocate for someone they love, especially when that person's vulnerable and can't advocate for themselves. But from the nurse's side, at what point does a family become like so intense, angry, suspicious, or hard to approach that staff actually start avoiding them or defending themselves or just kind of shutting down?
Well, I think that we get to a point where I question whether or not I, as a care provider, or we as a nursing facility, can meet your needs, can meet your expectations. And it's not that your expectations are wrong or excessive or that really doesn't even matter. What matters is whether or not we can meet your expectations in delivering the appropriate amount of care. And if the answer to that question is no, you're not, okay, are we capable? Are we equipped? Do we have the ability to meet your expectations to your standards, provide the care to, your liking and your preference? And if the answer is no, then we need to find somewhere else. And sometimes I think that conversation provides a little bit of perspective with families. Can they expect that they will find a facility that will manage their expectation, that will, meet their expectations? Whenever they start looking, they get a pretty good perspective as to whether or not that's going to happen, depending on what it is. Sometimes it's like, yeah, yeah, absolutely. Come on over. You transfer over here because we prioritize those types of things. And sometimes it's just, I find that I've had, experiences where the family has a laundry list of expectations that I would consider trivial, but it's the bigger picture is they're controlling what they can. And whenever they are out of control of a situation, they're not able to manage that person at home. They're not equipped with the knowledge or the resources to be able to care for someone outside of an institutional setting. It becomes a control thing. Like, well, I want to make sure that when I'm here, he gets XYZ, whatever it is, a nice fresh glass of water. Well, why isn't his water fresh when I come in? We'll set that expectation and determine whether or not it's realistic that someone will meet that expectation, or if we're just not capable because we're, too busy or too nonchalant or whatever the case is. And then go and find a facility that will meet those needs. If that facility exists in your area, a little bit of research, now that you know what your expectations are, a little bit of research into, the surrounding area or maybe a more convenient city or what have you would definitely help. But sometimes it's just not realistic. Sometimes all of the facilities in that area are going to be this way. They're just, call light wait times. You're going to wait on a call light at some point, if not every time, at least a few times a week. You're going to wait an exceptionally long time because of human life happening in the doors around you or behind the doors around you, you know.
So should those expectation conversations happen when you sign on the dotted line and enter that community?
I think they should, but they are not, because we're trying to, again, admit the most people that we possibly can. But I do think that there are opportunities for that conversation to be ongoing. I think that care plan meetings and, like I said, resident council meetings, and then, whenever you're in the building with your loved one, just having a quick conversation with a nurse or the nurse manager or somebody that, would be able to relay your preferences or your
Hmm.
expectations to the care team. I think that those conversations need to happen. I don't think that they do. Realistically, real world, they don't talk about that stuff on admission, or if they do, it goes in one ear and out the other. Uh, you know, it. I think that people tend to get labeled as needy or um, wanting too much, or whatever the case is, and ultimately, we just need to know if we're going to be able to meet those expectations or not. You mentioned something earlier about being very forthcoming with the level of care and with your expectations for the care that's going to be provided with your loved one. Don't hold back. You're not doing yourself a favor. You're not doing the resident any favors by kind of obstructing that conversation. That conversation needs to happen on admission and then frequently. And if it's not changing, if it's not improving, if it's not meeting your expectations, then you need to reevaluate and possibly move on.
So as a nurse invested and, empathetically connected to the care of that resident, are you the one who gets the privilege to have that conversation to reestablish expectations, or does management swoop in a very disconnected way and just try and sort of smooth things out? But in the end, not much happens.
It depends. If I know that the person who, a lot of facilities will say that it's a nurse management, function. It's something that the unit manager or maybe the director or somebody would normally handle. Maybe even social services would get involved here. But I I also have worked in facilities where I know that this person will be very dismissive. This person may not have the time. This person may not get along with the family quite like I think I would. And so sometimes I will have that conversation just knowing that it's probably easier to go ahead and just take care of it right now, discuss it right now, and then I can kind of report back to the team. But generally speaking, it would be your unit manager, your social services director, um, even like with the nurse practitioner and the doctors that make rounds. Whenever you are visiting and you see one of them and you need to discuss something with them, absolutely on the spot would be ideal, versus a meeting situation that you have to wait for and possibly have that situation unresolved until that meeting. So it just
So,
depends, I guess.
so those kinds of conflicts that I alluded to, there is a scenario where they can improve the care of the resident if the right communication choices are made. But
Absolutely.
at the same time, it could also make it harder for the family and the care team to actually work together.
It can.
What I'm
Yeah,
hearing is
feelings get hurt and egos get bruised, and, I feel like I may have anxiety to go into this room because I know that they don't like me, or that they accused me of something, or that they, whatever negative situation has occurred. But I also feel like the lines of communication always have to be open. I it baffles me that people don't realize, but like, we're caring for human beings. Like, these are humans. These are mom, dad, grandma, grandpa, aunt, uncle of somebody. And I think that everybody grew up differently. Everybody raised their children differently. Everybody has their own preferences and things like that. I feel like it takes a little while to be able to understand exactly what you like, exactly what you don't like. And it may take experiencing something before you realize, hey, I have a preference about that. I really don't like that. I didn't know that I wasn't going to like having a roommate because I didn't like someone else having the TV on, or whatever the case is. And so I encourage you to handle those things quickly, but also respectfully. I've seen, I don't know if I can even talk about this. One of my colleagues was recently attacked at work by a family member. And when I say attacked, I mean physically assaulted, and terribly, terribly. It was pretty devastating. And so you're also like, okay, well, I see that this person's angry. Are they gonna really lose it? And sometimes that happens too. So it's so bad. It's so bad because it could be so good. It could be so much better. And the problem is that it's not a one size or one fix, would solve the whole thing. It's such a multi-layered, convoluted problem because you have the families and the staff, and you've met people that let's say you go to Walmart, you get a cashier that you don't like. For every one that you do, you might get three that you don't. And no, obviously nothing against Walmart, but I feel like care providers are the same way, and families, they have
Families
preferences.
bring a
And
different dynamic also to the
Mhm,
bedside, and the relationships among different tiers within family and siblings. That it is complex.
mhm.
We're very sensitive to nursing violence. We've had several episodes on the podcast addressing that in detail, and I can only hope that your friend and colleague felt that somebody had their back going through that harrowing experience.
Yes. Yes.
So you've warned nurses to protect their license. What are the real stakes for a long-term care nurse when staffing levels, workload, management decisions just create unsafe conditions, but yet the individual nurse can still be blamed, disciplined, gaslit, reported, or fired if something goes wrong?
Well, I think that not enough people view it through the lens of, I think not enough nurses have perspective on this specifically. A lot of people think, and myself included, whenever I first started, I thought that a bad situation would be easily identified. And the truth is, a routine day 6 months from now, under review by strangers, could have been a bad day. You may not realize what occurred, and for some time. It could be days or weeks or years, before you realize the gravity of that situation. If your documentation was lacking, well, what really happened that day? And I think that not enough people realize how quickly that can change whenever you're working for people who tend to prioritize the company. People, a company that tends to prioritize budget. When you're working for a company that will look for a scapegoat in a situation, you are dispensable. And as much as I like to say, like, I'm pretty smart, and I'm a good worker, and I have all these great qualities, why would anybody hate me that much? Because if it comes down to you or them, they choose them. And that's not just with nursing homes, that's, any line of work that you get into. Generally speaking, that's how that goes. Well, now that I work in the courtroom, I see innocent documentation mistakes, innocent, things that turn into a lawsuit about neglect, negligence. People don't realize how quickly that happens. And it's just you signed your name in that chart that day, you gave that medication that day, something super routine that you normally do. Whenever you are involved with people who do not have your back and say, people that'll say, hey, you know what, that Mark would never do that. That's a good dude. He would never, people that will stand up for you in your absence. A lot of these facilities are not like that. They're like, hey, cut her loose, whatever. And people end up in handcuffs. People end up with criminal charges. People end up spending their life savings on attorneys for the next several years to fight something. People end up losing their entire career over just an innocent moment. Sometimes it's, malicious, but more often than not, it's something routine that was innocent, and it just got into the wrong hands and spiraled out of control. And you have no proof that it wasn't your fault, kind of thing. So I don't think that not enough nurses know that the situation is not easily identified as okay, this is when I should be worried about protecting my license. Those things don't reveal themselves until later. And so sometimes what was a routine day turns into a nightmare.
Just a thought that comes to mind with, technological aids exploding everywhere. Would a portable AI scribe to document these encounters actually save time and capture things efficiently to protect nurses?
I think it would. I've often considered, body cameras and things like that, but how do you do that and preserve the dignity of, human beings?
Absolutely.
But something that could, just transcribe the interactions and maybe even just an audio recording device in the room. I often feel most welcome in a room that has a nanny cam, or you know what I'm saying? Like I've done home health, and every single peds case that I worked, we had, cameras in the room. And that always made me feel better because I knew that there would be a visual to go along with the interaction. There would be, if anything ever went wrong, someone could replay that and see exactly what happened. But I think that unless it's a regulation, I don't foresee that ever being commonplace because it would cost quite a bit of money, that we don't have, kind of thing. So
Uh,
I think it
we
would be fabulous, though.
we do see the evolution of tools that can and are improving at maintaining confidentiality and that are being adopted in healthcare systems. So fingers crossed. So, in light of all these risks, how does that change the decision a nurse makes during a shift when they're trying to protect the resident, protect their license, and get to everybody who needs them?
My best advice is to bring a witness. Any situation that you feel like may need someone else's opinion or may resurface later in a different context, I would always grab somebody. Hey, do you mind coming in here with me? And then, I make a phone call. Hey, can we update the care plan to be 2 people or what have you? Sometimes you work with people I have worked with residents who were very manipulative in nature, um, and not necessarily to be destructive to that person's career, but to maybe get what they wanted. They wanted a reaction or whatever the case is. And sometimes people do that. And just being honest, sometimes that happens, and I take more than one person in with me. Um, that also protects the resident. So abuse is less likely to occur, negligence is less likely to occur if there is another person in the room, and I'm a huge advocate of that. Anytime I feel like it's needed, I request it. Is it feasible? Not always, but you can schedule things, juggle things to be able to, get somebody else in the room.
We're going to take a little break, folks, and get a chance to hear a question or two from our illustrious production team, which is a tradition we keep here on the podcast. We'll be back in a bit.
So, Chrystal, I've been listening to the conversation, and you mentioned earlier that eventually you're going to have to probably put your dad in a facility.
Mhm.
The comments that we get whenever we talk about this subject on the podcast are really split between a group of people that tell the horror stories and say they would never again do this, or like they had to pull their loved one out and take them back home. But for the families out there that are completely burnt out and can no longer provide safe care and really no longer have a choice about whether or not to put their loved one in long-term care, If you could sort of imagine yourself going to a facility and sitting down with the sales team, because I think a lot of issues sort of start there, how
Mhm.
would you approach that meeting if it was for your dad?
So if it were for my family, I think I've made a video or two about this just to try to give people some kind of structure to work with. But I would, number one, show up at an unannounced time, so that I knew that what I was seeing was organic, and not a presentation, because I can schedule a presentation anytime I want to. So I would say go at an off time. Or a time that you have not previously scheduled, maybe be a little early. I would also request things in writing. So if you have very specific needs, or if you have very specific preferences about maybe dietary requirements or your worship schedule for church, things like that are important to you, I would say make sure that you get in writing uh, the acceptance of those needs or those requirements, and that the facility does intend to provide those for you. I would also say to review the state survey manual. Usually in long-term care facilities, it's located. You can get it online, but a lot of us are pen and paper, myself included. So whenever I go into a building, I look at the survey manual so that I can see exactly what they were cited for. Was it super malicious, or was it something that could probably happen anywhere? And, kind of think to yourself. So just because they were cited for something doesn't make it an immediately a bad facility. Just look at what their plan of correction was. And if you can look around and see that they reasonably, it looks like they're trying to follow that, then I would say, you would look past it. But if they, racked up these deficiencies in areas that are crucial to the care of your loved one, then that should probably be your sign to move on and look for somewhere else. So also you can kind of observe whenever you walk in, like, what does it sound like? Do I hear a bunch of people yelling, or do I see chaos? How do I feel when I'm here? How you feel when you're there, is probably a representation of how your loved one is going to feel on a daily basis. If it feels rushed and chaotic and, kind of forgotten, or if it feels interactive and fun and, upbeat, you can get a pretty accurate vibe from just your initial interaction in a building.
Okay. The other thing I was interested in is you mentioned that there's sort of a different approach professionally to long-term care by generation. So what have you noticed around that? And can you sort of give us like where it cuts off? I recently had a medical procedure and I had this Polish nurse that had been nursing for like 35 years, and she made me feel immediately like she felt like my mom or something. And then there was a younger person in the room that also was doing a good job, but was less engaged. Um,
Mhm.
you know, the concern didn't seem to be as much about like calming my fear or making me feel comfortable, but the other nurse, the older nurse, really seemed to understand that and connect on a different level. That's just something that I noticed. Could you sort of break down
Mhm.
where the generational shifts occur and what's sort of the difference between the older generation and some of the younger generations coming into nursing?
Well, I think that the newer generations of nursing, I won't necessarily classify them as younger, just because I was older whenever I went back to nursing school. But I would say the newer generation of nurses has been rushed from day one. Whenever they enter their nursing program, it is crunch time. They are trying to manufacture answers for a test all the time, test taking, test taking, test taking. And so they don't learn necessarily the things that the veteran nurses have learned through a program where they had to wear stockings and a white hat. Those were very rigorous programs where you were dismissed for absolutely any reason. Not saying that nursing school isn't hard these days, because it's very tough. But I think that it started in nursing school, and the experiences that you had in nursing school. My particular program was very, they did things to prepare us, like, fake scenarios that still have PTSD from those. But anyway, so I think that the people that have been in nursing from the white cap era, that wore the white stockings in their graduation photo, those type of people, I think that they understand more of this generation that is currently in the facility. I also think that the newer generation probably tends to do a better job with mental health crises, with accepting people who are from different backgrounds or different sexual orientations and things like that. I think that the newer generation of nurses probably is a little bit more aware and respectful of that, as opposed to people, who, like I say, are from just a different time. Um, but I also think that the needs of the patient probably play a factor in that too. Sometimes we see like a younger uh, population in nursing homes, and maybe you connect with a newer generation nurse because you guys are more close in chronological age than. But I think that the older generation of nurses and the people who are up to probably their 50s, 40s, 50s, or as low as 40s, 50s. I think those people are more of a mother figure, if it's a woman, caretaker figure. And then the newer generation of nurses, I feel like, are probably more systematic about survival and just getting through the shift and making sure that you're okay, obviously. And this is in no way a diss. I just mean that the cultures are different, and you can that it becomes very obvious whenever you work on shift together. So
Thanks for
that's
answering my questions.
thank you.
So we're back from some really interesting perspectives shared by Chrystal in response to our producer's questions. Chrystal, getting back to how families and nurses can survive in the same broken system. When someone you love enters long-term care, the nurse is often the person you see first when something goes wrong. But what should families understand about what the nurse can actually fix and what has to be taken to management or the facility itself?
Well, obviously, if you feel like it needs to be escalated, please you know, don't even hesitate to go straight to the top of the chain. However, I think that if it's something that is preferential, something that your loved one prefers, let's discuss that on a one-to-one level. But remember that nurses are there to carry out physician orders. They are an entire person outside of their medical conditions. And I would caution anyone who I guess puts too much weight behind just the medical conditions and not enough focus on the person. I think it's easy to do when we get into the nursing home, because you on paper are your diagnoses. You on paper are your, care plan and your doctor's orders, but you're more than that. So if it's something preferential, minor, what have you, I would say just get one-on-one with the nurse. But if it's something that you feel like is a systemic issue, requires a policy update, maybe an explanation of sorts, or needs to be reported, something that you think should be maybe sent up to, a higher agency, thing like that, I would say definitely get with management. And sometimes that's whoever's door is open. Sometimes that's whoever you can schedule an appointment with, just depending on your facility and you know how available those people are.
I mean, in its purest sense, that's an avenue towards continuous quality improvement, just like any citations, maybe. Not all citations are actually meant to sort of harm morale, but they're actually agents of improvement.
Mhm.
If someone actually told me we've never been cited for anything, I think that would actually be a red flag to me.
Absolutely.
So, what belongs then in a conversation with a nurse? And if we can be a bit more granular, let's say the director of care or the administrator or levels up, what are those systemic issues that are present today in 2026 that need to be taken to higher levels?
Well, for starters, you know me, and I'm going to tell you staffing. If you feel like the problem is attributed to short staffing, inadequate staffing, incompetent staffing, a problem with the staff, I think that needs to go directly to the boss of those staff members. If you think that there's a systemic issue with maybe the culture, like you notice that all the staff, and I don't think that this is necessarily the case, but just for example, all the staff are just sitting on their phones at the desk and your call light's been going off for 2 hours, or whatever the case. Mom doesn't get a shower like she's supposed to, but the staff are, eating at the desk or whatever. If you feel like it's a staffing issue, then I would say, or a systemic issue with the staff, I would say, certainly move forward with the supervisors in that building. But I also think that if you want something different on the meal tray, if you think that, Mr. Joe needs a little extra time at the dinner table or whatever the case is, then I think those smaller things, those now things could be handled with the nurse, uh, because the nurse's reach is these people. These rooms and these people right now. If it's something that I would have to leave the unit for, you probably need to speak to management. But outside of that, if it's something that we're doing, if it's something that you've noticed that I'm not doing, certainly let's have a conversation, a respectful conversation.
Absolutely. And just trying to bring value to everyone listening. Before a family will actually trust a long-term care facility with someone they love, can you tell us what the top 3 questions might be that they should ask that might reveal what kind of care is there and what care looks like day to day in that facility?
I would ask what their ratios are. I would ask about their care provider ratios. How many people does the medical director see? If I have a concern and I need to see my doctor, like how long is it going to take me to get in? How many CNAs, or how many residents per CNA? How many nurses, or how many residents per nurse? Um, I would ask about make sure that you are seeing the actual room that they are gonna be in, because sometimes those things, I'm not pointing any fingers, but sometimes those things are a little switched around. Just be realistic about the person's environment, where they're actually going to be living, who their roommate is, things like that. And then I would also ask for advocacy phone numbers, point me in the direction of, where these phone numbers are. How do I get in contact with the state? How do I get in contact with the ombudsman? Make sure that you have that information so that in the event that something, I'm not speaking it into existence, but if something does happen, an
Hmm.
adverse event has occurred, you don't want to have to go into the building and go try to find a phone number with people who are trying to, who are in the same situation. I would rather not do that then. So I would say ask for relevant contact information then. Um, those would probably be my top 3 questions to ask.
I think those are important questions that don't establish a level of confrontation, but they rather establish that this is a family that's observant, that wants to
Mhm.
communicate, that doesn't have blinders on, that loves the person they're entrusting to the care of the facility. And
It would also indicate that they either have a healthcare provider in the family or they have spoken with another healthcare provider. It indicates to someone who works in this industry that they kind of know, they know things, whether that's because they have a healthcare provider in the family or because they've spoken to someone, they know what's going on.
so, on the flip side, then, when families are trying to decide whether a long term care facility is safe for someone they love, what answers from management should really make a family pause?
I don't know that they would ever necessarily disclose anything that would cause you to necessarily be alarmed. Um, Maybe in their responses, if you were to ask about the things that this facility has been cited for, again, there's a binder at in the
Hmm.
lobby, usually in these facilities. When you're going through that, if you have purposeful questions to ask and you feel like maybe the facility blamed the resident or blamed a family member or blamed the state surveyor, which I have heard also, um, and so kind of escaping accountability. If their response seems evasive or like it lacks accountability of sorts, then that would certainly be a red flag. But I'm not sure that even if the facility were capable of those things, they would disclose something that would give you that impression initially. Sometimes they're just putting their best foot forward and may not kind of trigger that in your mind right away.
Crystal, you've been a nurse and you've also been a patient. And when you were the one in the care bed, what did you understand differently about vulnerability, waiting, and needing care?
That was the hardest period of my life. I'm going to be honest with you. Um, for starters, I was jealous. I did not expect that I would feel jealous of the people that were providing my care. I remember I was crying one day after a procedure, and I told the nurse, I said, I was just like you, like last week. Last week, I was working as a nurse, taking care of other people, before all of this happened. And I felt like I was at their mercy. I'm at the mercy of your schedule. I'm at the mercy of your attitude in this particular moment. I'm at the mercy of what you tell the doctor. If you tell the doctor, oh, her pain is not managed or she's not responding, and I'm not part of that conversation. These are conversations that go on outside of necessarily the bedside, maybe at the desk, or they're calling the doctor or what have you, just making sure that if I asked for something, they knew that it was coming from a genuine place, because I don't typically try to bother people. I'm really, meek and quiet. And that was very hard for me. But I will tell you, I went to, most of my care was done at Indiana University. And the staff, the doctors, I even had a nurse just wrap her arms around me one day. Her name was Miss Flo. I remember this because she had on periwinkle blue scrubs, and I got my makeup on her, the collar of her shirt. She hugged me so tight, and I needed it. She, without even prompting, she just wrapped me up in her arms. They were fabulous. So while they could have exposed that vulnerability more than one time, because I was, there were times that I couldn't do anything for myself, they were fabulous. I had a very good experience, and I'm sure for every great one, there's, somebody who struggles and whatnot, but they were wonderful. They really made me feel at ease and heard, I think was probably the biggest thing that I felt like they were listening, and they did.
So, did being a patient make you feel more compassionate towards nurses or more angry about how much waiting, fear, and uncertainty patients are expected to endure?
I think it was a realization of sorts where I wouldn't necessarily say an epiphany, but I felt like I could sympathize with more than one specialty. I have been so isolated in, the nursing home and long-term care, maybe even dabbling in like the home health space. And so I know the problems of these areas. And I think by being a patient in the other areas, you realize how at mercy like the hospital staff, they're at the mercy of your insurance or, whatever the doctor says to do. So it's not always, even if you change the specialty, the problems are pretty relatively the same. And so I kind of empathized with the nurses about the struggles that they face, because I wouldn't have known that unless I were a patient in that setting. But seeing people show up every day with a positive attitude and compassion in their eyes, and they must do a really good job at burnout, training and things like that. I didn't come across a single person that I felt like I would classify as burned out or needed to take a break. Everybody just seemed fresh and eager to work every day.
Is that what distinguishes acute care settings from long-term care settings?
Not necessarily. I think that there's a huge there's a huge rift between long-term care and acute care. And not that all nurses of each specialty hate each other. That's not what I mean. But a lot of times we'll send a patient because it's a regulatory compliance. Okay. We have so many regulations that we're complying with. We'll send a patient to the hospital, and the hospital's like, hey, why didn't you send them sooner? Why didn't you take their vital signs? Why didn't you do this, this, and this? And a lot of times we don't meet those people. So they don't know if we're one of, if we're incompetent, or if I've heard us classified as incompetent multiple times, whenever really we're just following regulations or we're doing what our boss said we had to do. Not every situation that ends up in the emergency room was the fault of the nurse or a poor assessment, things like that. So there's always been kind of this back and forth between acute care and geriatrics. I think that both specialties are doing the best with what they have. And that's what it boils down to.
So, Chrystal, after everything you've seen, what do you wish families and nurses understood about each other before fear turns into blame?
That's a good question. I think that it's important that you realize as a family member that the nurses are doing their absolute best. Meanwhile, the families, generally speaking, are doing their absolute best too. It's very disruptive to have a nursing home admission, whether it's a temporary stay, whether it's a new long-term care patient, whether it's, like I say, a more acute situation, it's stressful for a family. We now we have bills that we have to manage and schedules and appointments and, whether or not things were done, following up. And then the nursing staff, I can't give people bonuses to make them show up to work. I can't make everybody happy in one fell swoop. I can't hire enough staff, or excuse me, I can't staff the floor with enough people so that your call light is answered in an appropriate amount of time. I know that those are deficient things, and I do my best to advocate when you don't see me. Uh, but ultimately, there's only so much in the control of a nurse or a CNA or insert another division of the nursing home here. There's only so much that we can do because we're bound to comply with policies, and ultimately I've got to do the most amount of work with the least amount of help. So I think that just understanding what both sides are going through so that you understand that ultimately you're on the same side, you know.
Just seems like in that moment we need to mutually acknowledge each other's humanity in the caregiving
Absolutely.
moment. If there's one thing a family caregiver could do differently the next time they feel angry at the bedside, what would you want them to remember?
I think it depends. I would say, give it the 5-minute rule. Is this gonna, or the rule of five, is this gonna matter in 5 minutes, 5 hours, 5 days, 5 weeks, whatever? Is this gonna be a huge issue? Is this a symptom of a bigger problem, or is this an isolated thing? But also just understanding that there's only so much control that any given person on the floor really has. So um, I would say remember that nurses are human beings and how you say things matter. uh, Providing context and adequate communication, clear communication of the situation. Try to remove as much emotion from it as you can. Not saying that if something causes you to be emotional, um, you're not wrong for that, but try to be, as clear and to the point when you communicate and be respectful, and if you feel disrespected or if you feel that you cannot have a clear conversation with a staff member, then by all means go to their supervisor or to the next person above them that will listen to you. So, um, yeah, I guess that's where I'll stop that. Yeah,
I wanted to thank you for sharing your empathy for the patient, for your colleagues, and for the profession, and bringing this conversation to light at a very challenging time for families, for patients, and for caregivers, both professional and family caregivers. As many acknowledge, we probably need to witness some sort of transformation of the deliverables and the system where patients will be put first and people will be put first once again.
I agree.
That wraps up another episode of the Caregivers Podcast. Thank you, Chrystal, for being here. And thank you, everyone, for listening. And we'll see you again next time. Chrystal, thank you for helping us look honestly at something many families experience but rarely get to understand from the other side. I think one of the clearest reminders from this conversation today is that fear can make people look for someone to blame. And in long-term care, when someone you love is waiting, when a need has gone unmet, or when the call bell has not been answered, the person standing closest is often the nurse. But the nurse on duty is not always the person who created the conditions you're seeing. It does not mean families should stay quiet. It does not mean they should accept poor care, ignore their instincts, or stop pushing for someone they love. It means the anger has to be aimed at the right level. Because staffing levels, budgets, management decisions, ownership, and facility policies all show up at the bedside. Families and nurses should not have to fight with each other for care that the facility should otherwise already be making possible. For anyone listening who is someone they love in long-term care and who's facing that decision, I hope this conversation helps you feel more prepared, more grounded, and more able to ask the right questions. I hope this helps you protect the person you love without losing sight of the people trying to take care of them. Before you go, please subscribe or follow the Caregivers Podcast wherever you're listening or watching. It is free and it helps support the show and helps these conversations reach more caregivers caregivers and families who are trying to navigate decisions they were never prepared for. And if the Caregivers podcast has been helpful to you, please consider buying the team a coffee. We're a new independent show, and every bit of support helps us. It helps us keep bringing these conversations to caregivers each week. The Buy Me a Coffee link is in the show notes on YouTube, Apple Podcasts, and Spotify. Thanks for listening, and we'll see you next time. Before we wrap up, I wanted to remind you of something important. The conversations you hear on this podcast are here to inform, to support, to spark reflection. They're not a substitute for professional medical advice, care, therapy, or crisis services. Listening to this podcast does not create a doctor-patient or caregiver-client relationship between us. If you're facing a medical concern, health challenge, a mental health challenge, or a caregiving situation that needs guidance, I encourage you to reach out to a qualified professional who knows your story. If you're ever in crisis, please don't wait. Call your local emergency number or recognize crisis hotline right away. You deserve real-time help and support. The views you hear on this show, whether from me or my guests, are our own. They don't necessarily reflect any organizations we work with, or are part of, or have worked with, or been part of in the past. This podcast is an independent production. It's not tied to any hospital, university, or healthcare system. Thank you for being here, for listening, and most of all, for taking the time to care for yourself while you continue to care for others. I look forward to hearing from you.